So, Dr. Ince, is there any way to translate your findings into a clinically usable tool? Wouldn't it be more informative to measure tissue oxygenation tension, for example, using near-infrared spectrometry?
Near-infrared spectrometry is actually measuring a mathematical formula.
Okay.
It's not measuring, so it measures a composite number of an uncertain compartment, a bit like laser Doppler. As I hope I showed, the technique that we propose allows you to give a differential diagnosis about the underlying abnormalities that you see and provides you with insight into how to correct them. Tissue oxygen has also been proposed but has never really been successful because oxygen electrodes only have a penetration depth of about 20 micrometers and can only be used for cutaneous measurements. So, and does not tell you what's going on. So all of these tissue oxygenation measurements are really surrogates of microcirculation abnormalities.
Thank you. This question is for you. Should single kidney patients with evidence of early stages of CKD, G2, be discouraged from becoming pregnant?
Yeah, so I think this is a discussion, individual discussion with patient, physician. There is increased risk for pregnancy complications in these patients, but most of that is term preeclampsia, which is mild disease, and 90% or higher at that early stage tend to have live births. So I think these patients need to be counseled, and it's a discussion between the doctor and the patient, how much risk that they want to take. But many of that can be managed.
Thank you.
Yeah.
For Dr. Navaneethan, is there any guideline on how to use SGLT2 inhibitors for patients with DKD and peripheral artery disease?
No, I would be cautious, and as you may recall that with the CANVAS program, we already have seen that there was an increased risk of amputation. I don't think there is any formal guideline with respect to the use of these agents, but I would certainly be cautious. Some of these patients were excluded from the Credence trial, and we didn't see the increased risk of amputation. So with all those things in mind, I would be cautious.
Thank you. Dr. Ince, is erythrocyte shape and size affected by oxygen saturation?
Not as far as I know. What is important about red blood cells is red blood cell fragility, and fluid resuscitation causes red blood cells to become more fragile and can open the way to hemolysis. And in my opinion, free hemoglobin is one of the most important biomarkers to measure in various states of disease. So the fragility of the cell membrane is certainly an important area to look at. Does not affect tissue oxygenation, as far as I know.
All right, thank you. Dr. Navaneethan, does intradialytic hypotension affect fetal survival? Does intradialytic hypotension affect fetal survival?
Yeah, I don't think so. I don't think there's any data that in general you avoid intradialytic hypotension by sort of either cooling the dialysate and all the other. I don't think there's data that I can sort of point to that's been linked with that.
Can I stay with you and ask you if anemic pregnant women with CKD are able to be treated with HIFs, PHIs?
Oh, this is an interesting question. So this is with the newer prolyl hydroxylase inhibitors. I think that we don't have data. I'd have to look at that. These prolyl hydroxylase inhibitors, essentially, as you know, create chemical hypoxia in the liver and induce EPO. So in pregnant women, I don't think we have data. Because these are small molecules, they perhaps cross the placenta into the fetus. And the question is, will there be side effects from that? I don't think we have data to sort of say. So today, we would just use EPO, but this is something that I'd have to check.
Thank you.
Yes.
Dr. Ince, clinically, we consider ischemic acute tubular necrosis in patients who develop macrocirculatory failure, and we expect more severe and prolonged acute kidney injury from it. Do you have any studies correlating microcirculatory failure or anemic shock with severe acute kidney injury?
There have been many studies that have looked at the determinants of acute kidney injury, and have related that to the development of clinical progress. The most largest examples of that indeed have been associated with abnormal microcirculatory perfusion and contrast-enhanced ultrasound.
All right, thank you. I'm going to show this question to...
It's for you, for the SU.
Yes, thank you. Would you mind reading it out loud?
Okay. Thoughts of the potential new non-steroid mineralocorticoid receptor agonists such as finerenone for reduction of albuminuria and heart failure in diabetic patients. How will these change care if approved? So there are, at least in 2015, there was a clinical trial, a phase 2 clinical trial that was published in JAMA that tested the use of mineralocorticoid antagonists. We know spironolactone and eplerenone reduce proteinuria. However, there is increased risk of hyperkalemia. So this novel MRA had the same benefits but lesser risk of hyperkalemia. This is being now tested in 2 large trials, Fidelio and Fidalgo, I believe. Their results are expected in the next couple of years. That's one compound in contrast to SGLT2 inhibitors. So that's another thing that the guideline committee has taken into account. Like, we see these trials could come out, and we have to see, what is it on top of, right? I mean, so are these people on ACE and SGLT2, and are you going to add these new agents? Or there may be some patients for whom this SGLT2 might not be an option, or they might not tolerate. For them, are these going to be an option, these newer mineralocorticoid receptor agonists? So I think we're entering somewhat into a precision medicine. We may have opportunities in future if all these clinical trials pan out for us, that we may have opportunity to pick and choose for our patients, or maybe choose combination therapy. It's too premature to say whether this study would be positive or not, at least from my opinion.
Very well, thank you. So I have a couple of questions for you, and he has to catch a plane, so he's going to go ahead and answer some of his questions now.
So what's the turnaround time for getting the results of SFLT1 in your institution? I think it depends. Usually we're there 5 days a week. I would say 48 hours or so. If people send the lab, results, we do them for free, so people can send samples to us, and we're happy to do them. The second question is, why hasn't the FDA not approved the SFLT test? So there are two, there are 2 ways by which the FDA approves diagnostic tests. One is called a 510K approach, and the other one's called a pre-market approval or a PMA approach. And because these tests are used in pregnant women, and decisions about continuing pregnancy are being made based on the test, the FDA insists on sort of the larger, not a 510K approval, which tends to be an easier path. And so this means that they have to have like 2 large studies, clinical studies, to sort of go and show demonstration that there's no harm, from the knowledge of the test. And so these studies are now ongoing. So one is primarily a prospective clinical study that's out of University of Chicago, and then we're doing a study as well out of Cedars. So we'll have 2 studies that hopefully in the next couple of years will be sufficient for the approval of these tests.
I think there's one more for you.
So what's the volume? There was a question on volume?
Yeah.
For dialysis patients with hypertension, the maximum dose of antihypertensives, how would you manage volume? I think for dialysis patients, it's just, you do a lot more dialysis, so the best way to remove volume is, who have significant sort of hypertension is to, because you're doing so much dialysis, is to actually increase the ultrafiltration during dialysis.
Thank you so much.
Thank you very much.
I know you have a plane to catch, and we want to thank him for his wonderful presentation.
Thank you. Yes.
Yeah.
So we have a few more questions. What is the role of insulin in diabetic patients with CKD?
So if they need it for optimal antihyperglycemia, to reduce the blood glucose, yes, of course. We know that as their kidney function declines, the risk of hypoglycemia goes up and the need for insulin goes up. We didn't see any clinical trials that are testing different compounds or anything, in our search at least. We have newer agents, of course, that are also acting in a similar fashion, so we have few more trials are on the way. Currently, I would say as nephrologists, we are not used to managing, so I would still take the help of endocrinology colleagues. I wouldn't take up the insulin on my shoulder for management. At least for this group, that's what my recommendation would be.
Very well, thanks. We have a number of questions for Dr. Ince. How do we avoid intracellular dehydration in sepsis?
I think that's a very important question. The problem, of course, is how to get water inside the cells. So basically, you're going to have to administer glucose. And what glucose does is it, if the transporters are working, will enter the cell and will take water with it. So what's a real challenge is to be able to identify the difference between hypovolemia and dehydration in patients. And I think the bioimpedance device turned out to be very, very useful to be able to differentiate between the two types of dehydration.
Very well, thank you. I'm going to stay with you for a moment. And does the type of fluid, for example, Ringer's lactate versus normal saline, make any difference in microcirculation?
In the macrocirculation?
In microcirculation.
That's a very good and important question. So there's a trend now very much because people want to avoid dilutional acidosis, which is basically diluting the bicarbonate and giving what are referred to as balanced salt solutions. So the one which is used the most is Ringer's lactate. But because there's no industry pushing Ringer's lactate, there's relatively poor evidence about what Ringer's lactate does. But what needs to be taken into consideration is that Ringer's lactate, even though it is balanced and will not lead to chloride acidosis, what does happen is that lactate is converted by gluconeogenesis into bicarbonate and makes glucose, basically. So actually, I would suggest, just from a physiological point of view, that it should be contraindicated for diabetic patients, for example. A much better alternative to Ringer's lactate is a Ringer acetate. Ringer's lactate takes approximately 45 minutes to an hour to metabolize into bicarbonate, whereas acetate does that in about 10 minutes and also is done by all the organs. And Ringer's lactate requires good liver function, which is also not present in a lot of critically ill patients. So I would certainly prefer an acetate-based balanced salt solution to Ringer's lactate. Also, Ringer's lactate, of all the fluids tested, is the most pro-inflammatory fluids which there are. It upregulates tumor necrosis factor and IL-6 more so even than sodium chloride.
I have a question. Well, let me ask you one more question, and then I'll move to you. You can join me here. I don't bite. And that way we're closer. Thank you. One more question for you, Dr. Ince. Is the sublingual vascular bed an alpha receptor region like the skin?
No. The sublingual area is actually, which has been shown by many studies now, is a very, very sensitive organ because the skin, the function of the skin microcirculation is mostly for thermal regulation. And sublingually, it's much closer to heart and brain function. So many studies have been performed, close to 600 actually, looking at the sublingual area. And you can also make a differentiation between the larger and the small vessels, and you can see leukocyte kinetics underneath the tongue, which you can't really see in skin very well.
Thank you, Dr. Ince. Dr. Navaneethan, any recommendations regarding glucose content in PD solutions in diabetic patients on PD?
Well, at least, for this guideline, you wouldn't see anything relating to that. This was not the, when you come up with guidelines, you have preset questions that are of importance and interest to people. So this was not one of those. But in the absence of it, I think probably the same target that you would recommend for the other people could be used, and what solutions are they better? Are there clinical trials showing that one better than others in terms of outcomes? At least to my knowledge, no. I'm not a PD expert to expand on that.
Thank you.
Yeah.
Dr. Ince, is the Videoscope you use for your visualization of microcirculation commercially available?
Yes, it is. Actually, we're working on that. So the only problem is that it's rather expensive. It's about 30,000 euros. It's widely used in Europe, but not so much in the United States. So we are now working on a much cheaper device and using artificial intelligence to understand the abnormalities which are present.
I have one more question for the doctor. A very popular session, as the number of questions show. How closely is microcirculation and cardiac output correlated? Is it the same in all vascular territories?
That's a very good question. It's the one that's asked the most. Is sublingual microcirculation, does it reflect other organ beds? And the way to look at it is that there's really no measurement in clinical medicine at all which measures something in one location and assumes that it's the same in other locations. One looks at the clinical significance of measuring underneath the tongue and looks if it's giving you additional, more sensitive information than other measurements, in this case hemodynamic measurements. So if you look at cardiac output, probably the best studies which have been done concerning the role of cardiac output have been done in ECMO patients. And there you see very clearly that there is a very short range, at least if you have a non-immunocompromised patient, in which the cardiac output follows the microcirculation. However, in most states of critical illness and in perioperative medicine, you see that even though you might increase the cardiac output, you see relatively little response in the microcirculation. So that is why this whole area of hemodynamic management has focused itself so much on the futility of chasing cardiac output and mean arterial pressure as a hemodynamic target, because these measurements have shown the complete ineffectivity of chasing certainly blood pressure by vasoactive compounds. So at least in Europe now, there's a lot more tendency and focus on using vasodilators for improving hemodynamic management of critically ill patients than using the vasopressors, which actually have the adverse effect on improving tissue perfusion.
We look forward to those publications.
Yeah.
Thank you. Sankar, thoughts of the potential, and I know it's a little bit out of the guidelines, but thoughts on the potential of new non-steroidal mineralocorticoid receptor agonist MRAs, such as, well, I'm not going to give the name, for reduction of albuminuria and heart failure in diabetic patients, and how will this change care if approved?
We talked about probably it might be the same or a follow-up question. So we know that SGLT2 inhibitors also recently have shown that there was a reduction in heart failure. Specifically, there's a DAPA heart failure study. So the SGLT2 inhibitors have been across the board, has been shown. So these agents, the newer mineralocorticoid receptor antagonist, finerenone, is being studied specifically for two things, because spironolactone currently is the class 1 recommendation if people have advanced heart failure. It's a level 1 recommendation, at least for heart failure patients. So would this agent have dual benefit? Would it reduce heart failure? Would it improve kidney outcomes? And that's yet to be determined. These two ongoing trials that I mentioned are examining these. These are very large trials, 10,000 patients, I believe, in each of those things. Is expected to come out in the next couple of years. And it would be interesting also to see how many of those patients in the trial will be on these newly recommended agents to improve outcomes for our patient population. I just want to reiterate the point that it is nice that we have all these trials that are examining different pathways. If they all come to fruition, we will have multiple options, but we have to wait for a couple of years, I believe, to see these trial results.
Dr. Anjay, I read with interest your publication on the blood purification issue, which is in our apps. And in that publication, you mentioned this point-of-care handheld vital microscopes. Can you tell us, do you see great penetration of this handheld devices, and how expensive would they be?
Yes, because certainly in areas where there's this disassociation between conventional hemodynamic monitors and what's going on in the tissues. So titrating various types of resuscitation procedures really requires that you know when there's a futility of resuscitation. For example, we've seen using these microscopes that in certain areas when you give a blood transfusion, that even though in all situations arterial hemoglobin levels go up, you see that in certain situations there has no effect on improving the red blood cell availability in the tissues. So this way you might be giving, and that's the so-called non-responsive patient. And this is something that I think this technique can address, because the non-responsive patient means you don't know what's going on, basically. And by looking at the various patterns in the microcirculation, you can get a more deeper understanding about whether there's an inflammatory component, where there is a dilutory component, where there's a rise venous pressure which is causing a tamponade, or whether there's edema. And all of these together are very difficult to disassociate when you're just measuring cardiac output or blood pressure or saturation. So I think the great advantage of this technology will be that it will allow you to get a deeper insight into the underlying pathology, and more importantly maybe to give you an endpoint for resuscitation, but also a futility of resuscitation, to tell you to stop doing what you are doing. Because in my opinion, there are too many green lights, certainly in critical care medicine, telling you what to do, but there are very few techniques which are telling you to stop doing whatever you're doing. And I think that will be a major contribution.
Thank you. Thank you so much. So I have one last comment, and I want to thank our speakers for the fantastic presentations this afternoon. I always, when I round with my residents and students, and I sit with them, I always ask them, what did you learn today that you didn't know before? And since they know this, when they're rounding, and they also are in small groups, they're not allowed to repeat the same comment. So they pay attention when we're rounding, but it's a great feedback teaching technique. So I'm going to apply it to myself. What did I know today? What did I not know? That I learned so many things today that I could just go forever. But I would like to make a comment for our pediatricians particularly. So we do know that children who had pediatric onset acute kidney injury, as adults or young adults, will be at greater risk for CKD. What I was interested in hearing was that AKI can be associated with pregnancy-related outcomes. So let's remind our adolescent women and our young adult women that if they're going to get pregnant and they had a history of acute kidney injury, they should alert their obstetricians about this incident, this particular complication. I want to thank the audience. We finished with about 10 minutes to spare. No, 3 minutes to spare. I was excited about being early because we had a little bit of technical issue. Thank you for your time and questions.